During this session, we're going to give you an overview of autonomic dysfunction, how to identify POTS, management. We're going to talk a little bit about some of the tools that are available to support you with your work. We'll have a patient perspective, a case study, and then some Q&A sort of in the middle and again at the end of the session. So what is autonomic dysfunction, or also known as dysautonomia? Well, it's when the automatic or the autonomic nervous system malfunctions. That's the nervous system that controls all the bodily functions that we don't have to think about. And that includes things like control of your pupil in your eye, breathing, gut, sweating, your renal system, and it also controls your heart function and your blood vessel, in particular, the dilatation and the narrowing of the blood vessels. And when these two last functions malfunction, it's common to experience orthostatic intolerance. And orthostatic intolerance is the development of symptoms in the upright position that are relieved by lying down. And that the symptoms are these usual pre-fainting symptoms, such as lightheadedness, difficulty thinking, sweating, feeling shaky, nausea, and so on. And orthostatic intolerance can be part of a number of different syndromes, including vasovagal syncope, POTS, orthostatic hypotension. You could put inappropriate sinus tachycardia in there. And then non-specific orthostatic intolerance, which is basically when people have the symptoms but don't quite meet the criteria for these other syndromes that I mentioned. So I'm now going to focus a little bit about orthostatic intolerance in the long COVID setting. Approximately half of people with long COVID experience orthostatic intolerance, and we get similar statistics in children as well. And those people with orthostatic intolerance, this is strongly associated with suboptimal health status. And in the long COVID setting, orthostatic intolerance can be due to orthostatic hypertension, and in fact, in some studies, they're finding that more commonly than POTS. Vasovagal syncope, POTS, and non-specific orthostatic intolerance. And there was a collaboration that started in 2020 between NICE, SIGN, the Scottish version of NICE, and the Royal College of GPs. It was the first collaboration like this that they'd ever had. And they worked together to develop the long COVID guidelines that I'm sure you're all familiar with. And in that guideline, it recommends an active stand test in long COVID in patients who experience these symptoms of orthostatic intolerance. So how common is POTS in long COVID? The answer to that is that it's not clear. There have been a wide variety of reports, ranging from none in one study to, in fact, up to 50% in one where they actually used symptoms, and I should say a rather dubious definition of POTS, but it was, I think it was 7% in the locomotion study, and none was found in the controls. And the reasons for this variation are varied. Just to give you one example, there's a study where I've already mentioned they found no POTS in their patients, but actually it was in a setting of a medicine for the elderly clinic, and their population was a bit older. They tilt tested patients on medication, including beta blockers, so that would have blunted the tachycardia. They excluded people who fainted. And also when people were being tested, if they had marked symptoms, they aborted the test. And so it might be in for that example, they were actually excluding all their POTS patients before they did the study. We're often asked about the terminology. Is it POTS with a capital O or a small o? And the background to that is that in the US and a number of other countries, they call it postural orthostatic tachycardia syndrome. But Professor Mathias in 2011, in a publication in Nature, proposed that the orthostatic be removed because the postural and orthostatic mean similar things. And so often, but not exclusively in the UK, we tend to use the convention postural tachycardia syndrome. There is coding for postular orthostatic tachycardia syndrome, and the ICD coding, which is used internationally, is a code of diseases, and you can see two codes for that there. They're sometimes used in the UK more for hospital admissions than for actual hospital attendances. And then there's the SNOMED coding, which includes not only diseases, but symptoms and tests and medication and so on. And that's used in primary care throughout the UK. And there is also a code on there for that. And I've actually asked them if they'll consider putting in postural tachycardia syndrome and just POTS so that more people can find it. And they've agreed to consider that, and we're waiting the outcome. So what happens when a healthy person stands up? Well, immediately, a large volume of blood will drop down from their thorax into their abdominal cavity and limbs. And there's immediate vasoconstriction, which helps to squeeze the blood back up to the heart. There's a slight increase in heart rate of 10 to 20 beats per minute. That's normal to compensate. And that allows blood to circulate and go on up to the brain. But in POTS and some forms of vasovagal syncope and orthostatic hypotension, this mechanism doesn't work properly, and blood tends to pool in the abdominal cavity and limbs. There's less venous return to the heart. There's excessive tachycardia with the heart trying to compensate. And then there's reduced or altered blood circulation in the brain. There's a lot of overlap between the syndromes of orthostatic intolerance, but generally speaking, in vasovagal syncope, patients tend to have episodes, sometimes quite catastrophic, periodically, but they're generally well in between times. Whereas in those with orthostatic hypotension and POTS, they can often be symptomatic every time they stand up or even throughout the day. In these patients, the inadequate vasoconstriction leads to a relative hypovolemia blood volume, meaning that the normal blood volume is too small for the extended capacity of the blood vessels. And that results in the symptoms of orthostatic intolerance. And these include things like ringing in the ears, headaches, difficulty thinking, which patients often find is the most challenging of symptoms, visual disturbances such as graying and glare, shakiness, fainting, sweating. And in POTS, the commonest three symptoms in over 90% of patients are lightheadedness or dizziness, fatigue, and fast palpitations. So just some observations from some of the earlier studies looking at POTS in long COVID. It's often younger women that are affected, but not exclusively. It can be children, men, and older people too. Often, but not exclusively, the patients have not been hospitalized. And patients often have really quite marked cardiac symptoms. They experience a crushing sort of chest pain. They can experience breathlessness and palpitations, but their cardiac tests are normal. They're usually treated with lifestyle measures and then the usual medications. And interestingly, they quite often seem to notice that they had minor autonomic symptoms before their diagnosis of long COVID or before their COVID-19 infection, and they perhaps just didn't realize the significance of them at the time. But generally speaking, there are early indications that long COVID POTS mirrors non-COVID POTS. It's not a new condition. It was defined and diagnosed in 1993, but it's thought to be the same thing that was described by Sir James Mackenzie in 1916 in the BMJ when he called it the soldier's heart. And it's often thought by experts to be the same as Da Costa syndrome described during the American civil wars. There are a number of comorbidities that are associated with POTS, and I'm now talking about the POTS that we were seeing prior to COVID-19 infection. And the commonest comorbidity is the hypermobile form of Ehlers-Danlos syndrome and hypermobility spectrum disorder. And interestingly, there has been a report that this seems to be a little bit more common in long COVID patients. It's commonly found in ME CSF. There is an excess of autoimmune conditions in patients who are affected by POTS, a variety, in particular Sjogren's. Mast cell activation, which involves multiple allergies and flushing, is common in POTS, and of course you're also seeing that in long COVID. And we weren't surprised to see POTS in long COVID or after COVID-19, because we've been seeing it for a long time after other viral infections, including the Epstein-Barr virus, which is glandular fever. And sometimes associated with POTS, patients experience what we like to call non-hemodynamic collapse, sometimes called psychogenic syncope, but there are a variety of names for this condition. POTS is commonly misdiagnosed, and in a study we did in 2015, we found that half our patient population had been misdiagnosed with a psychiatric condition for their physical symptoms, and this occurs way more commonly in women compared to men. And the common sort of psychiatric misdiagnoses are anxiety, panic attacks, depression, and hypochondriasis. And consequently, before the pandemic, there was a mean of a 7-year wait to patients receiving a diagnosis of POTS from symptom onset. This, in our experience, seems to be less since COVID-19 pandemic. Otherwise, you wouldn't be seeing any of it at all at the moment. POTS is often described as an invisible disease. That means that the patients can often look well, but are really quite debilitated by their symptoms. Prior to the pandemic, it had been estimated that it affected 0.2% of the population, and we suspect it's more than that now. As mentioned before, it can affect all ages and sex, but it's more common in younger women. And the disability has been equated to equivalent to significant heart failure and COPD. But, remember, these are conditions that affect older people, and what we're seeing is often actually in younger women in their formative years. We found that 25% of patients were wheelchair users, mainly because of the increase in their symptoms when they're standing, and 50% of children in our cohort were off school in the long term. Symptoms tend to fluctuate just like they do in long COVID, and this can make it very difficult, for example, for patients to get back to work after they're starting to feel a bit better, because they often have frequent relapses. But it's really important to identify it, because 80 to 90% of patients will significantly improve if given appropriate treatment. When should you screen or think about POTS? Well, if you're presented with a patient with a sort of multitude of non-specific symptoms, I often see they've got really long medical notes and no clear diagnoses, and that would make me start to think of autonomic dysfunction and POTS. And particularly when patients describe symptoms that are related to them being upright. Although sometimes that's difficult, because some symptoms, such as the brain fog and fatigue, can occur after they lie down, and so sometimes it's difficult to make the relationship. And obviously have a very high index of suspicion in these comorbid conditions that I mentioned earlier. Certainly ask about postural symptoms, and some people would argue that you should do a stand test in people with ME CSF. There are a number of questionnaires that can help to either identify, or particularly they were designed for scoring symptom severity. One of the early ones was the Autonomic Symptom Profile, but it's got 169 items, And for people with brain fog, that's really hard for them to complete. There's the Compass one, which has got 84, and that was abbreviated to Compass 31, which is 31 questions. And more recently, the Malmo Pot score system was developed, and that's got 12 items